Hello, and welcome to the Longitudinal Integrated Clerkship Podcast. I'm Dr. Meghan Geary, the director of the LIC. LIC students are part of the primary care and population medicine program, and they are required to follow a panel of approximately 2 to 3 patients per specialty over the course of a year. This includes all people, geriatric patients, pregnant people, and for these patients, students serve as advocates and navigators and attend physician visits, surgical procedures, deliveries with patients on their panel. And then students can also check in with their patients between visits by phone or via the portal or a message. Your LIC students, therefore, can develop relationships with their panel of patients beyond the clinical day. And following patients longitudinally provides multiple benefits, including improving students' understanding of their social and cultural context of illness, the illness's impact on the person as a person, as well as gaining a depth of medical knowledge and a fuller picture of a disease course. And students develop a stronger sense of patient-centeredness, which follows them throughout their professional careers. Following patients longitudinally forges a bond between students and patients, providing the patient with a sense of connectedness to the practice and practitioners. How can you, as an LIC preceptor, assist students in following patients longitudinally? With us today is Dr. Sybil Cineas, who is an associate professor of medicine and pediatrics here at the Warren Alpert School of Medicine. She too is the associate director for the MedPeds residency at Brown and the assistant director of the LIC, and has been in leadership and an LIC preceptor since the program started. Welcome, Sybil. Is it okay if we call you Sybil today on this podcast?
Yes, and is it okay if I call you Megan?
Of course, absolutely. Our first question to you is, how do you, as an LIC preceptor, help your student to follow patients longitudinally?
Thank you. Thank you, Megan, for having me, and Dr. Smith as well. That is a wonderful question. As you've mentioned, I've been with the LIC since the beginning, and it's been wonderful working with students. Students in my practice see both pediatric patients as well as internal medicine patients, and fulfill their requirements for both those longitudinal clerkships while working with me and one of my colleagues for basically 2 half days per clinic. So we have the advantage of having them for 2 half days, so they really do form a they really are in the environment a little bit more and really get comfortable with that space, as well as with the staff and the patients and the preceptors. So, following patients longitudinally is pretty much at the core of primary care. That's what we do. And so to that end, I really like to empower my students to really think of themselves in that role. So to that end, patients who work with me are assigned their own patients. They have their own schedule. I know that this is not something that everybody can do, but it is what I have chosen to do with my patients and with the time that I have, with my student, with the time that I have with them. So I introduced the student as part of the team. Basically, they're an extension of working with me. And I empower the students to have the primary responsibility for all aspects of their care, and that includes the patient visit itself, the documentation of the patient encounter, as well as communication after the visits, including communication regarding test results. So I think that this requires both buy-in from the student as well as buy-in from the preceptor. So that means that when I am receiving test results for our mutual patients, or communications from specialists, or reports from the emergency departments if they visited that setting, that means that I am forwarding all of that information to the students so that they can remain informed in between visits of what is going on with their patient, in essence. So that's one thing that I think can be helpful with continuity. In addition, like at the end of the visits with the patients, I encourage my student to walk the patient to the front desk to schedule their next appointment, hopefully at a time that is mutually beneficial for both the student and the preceptor, and that helps to ensure continuity. Uh, Another thing that has been helpful in terms of both providing feedback to the student as well as to keeping track of the patients that the students are seeing in clinic is I have them, because the student does write documentation, I feel that they deserve to get feedback on that documentation. So they keep a binder that's kept in the clinic so as to preserve HIPAA with the clinic notes that they've written. And even though I do review them electronically, I also will provide feedback on the notes that they have written in the binder that the student can then access. It is also a great way for the student to remember who they've seen. And sometimes when a patient doesn't show, we go through that binder and find people that, oh, we need to follow up on this, or let's make sure that this happened. And that really helps with getting patients back in and to keep the student involved. Let's see, what else did I miss? Or what questions do you have about any of that?
What I hear is that you're really having your LIC student be the primary care physician. And I imagine in the binder, you're seeing the student's medical growth over time and their understanding of disease course and their ability to document. I wonder how you pick patients initially for the student's schedule.
That is a good question. I don't necessarily pick them. My schedulers do have access to it. Our staff is well aware of patients that are appropriate and not appropriate for that visit. The other thing, patients who are usually, I have availability, and so sometimes a patient may ask for a visit and there's nothing available for months, but I might have an available slot with the student. And so the staff knows to let the patient know, you'll be seeing Dr. Cineas in the sooner appointment. She is working with the student, so we make sure that we have consent, or at least that they're aware that they're going to be seeing a student. And in fact, they actually get more of my time this way because those are they're longer visits. And so they got the time with the student, and then they got my time with the teaching as well, because we like to do bedside presentations for the most part.
Absolutely. I was just thinking about how you have your student present in the room. How many student patients do you schedule on average?
3. So it's an hour per visit to include the independent assessment by the student, and then their time precepting with me and wrapping up the visit. So hopefully we're done with all that. And I schedule my student during an admin time. So I'm typically doing some other things while they're seeing the patient independently in the beginning, and then we go back in together.
Thank you so much for describing some of the details of your structure. Changing a little bit to the experience of patients, what have patients told you that their experience has been with a student following them? Are there benefits that they bring back and tell you about this?
Yeah, I think that one of the benefits is that they're having a visit that feels a little less rushed, which I think they enjoy being able to, tell their story and also have the attention. I think that they benefit from the teaching that happens at the bedside. And so they're learning as well as the student is learning. And then other benefits that they'll encounter is when the student has been able to follow them across other sites. I think they find that as a source of support and also helpful to navigate the system.
Absolutely. Are there any experiences that come to mind that students or patients have told you about when they've been able to see each other somewhere else in the healthcare system?
Yeah, I think that from the student standpoint, I think it's really important to have the perspective of what it's like to, go someplace outside the system, from the logistics of getting there to like scheduling, to the parking, to language barrier, or what it's like to like wait in the waiting room. what it's like to be in the room, what the patient understood versus what the student understood. Sometimes it's helpful in terms of after the visit, the patient may not have understood something and the student is able to explain it. But it also is helpful to see really what the barriers are. I had a student follow a patient to a surgical appointment and then to the actual surgery. And it became apparent the day of surgery how ill prepared the system was in dealing with a patient with a language barrier. And that was really, really important that the student was there as he was able to, a little bit serve as an interpreter for the patient for that encounter. It really brought to light the availability of interpreters like in the surgical setting in terms of like all the way like going into the OR. So that was a barrier that we, had not necessarily thought about or predicted would be an issue for this patient. So it was extremely helpful that the student had been there.
It's so interesting to see that like insider outsider perspective on the system that we might not be seeing from the clinic. I think I as a director, and you often talk about like the barriers students might have following patients. Are there any ways you've found to prevent those barriers for students?
I think it's difficult. I think the biggest barrier is finding, the mutual time. So sometimes the time that is convenient for the patient, which is the priority, obviously, is not a time that the student has available to follow that patient. But I've had some success. The students have been able, especially once they're really comfortable in their role and comfortable with their preceptors, they've been able to navigate some schedule changes to allow some of these longitudinal experiences. And it's really been, beneficial for the student to like be in those settings. So I had a student follow a patient into the ER and just, seeing what that's like to be with somebody in the ER and like the wait time and then going through the entire like visits, the visit and like being in that setting is experiencing that firsthand. I think is really important. And it informs your practice going forward. Like, next time you want to send the patient to the ER, is that the right, like as they like to say, is this the right care in the right setting? Because we had debated sending this patient to the ER versus seeing her in our office, but in the end, felt that the ER was the best place at that time. But I'm not so sure thinking about it moving forward. But it's a good thing to think about whether we're sending people to the right places.
Agree. I think students sometimes make all of us reflect on our practice and have that time to follow up and think about things. Are there things that I missed that feel important for our conversation? I just hear so much about like the value of med peds and getting to see children and adults with the same preceptors and the same practice over the whole year.
Let's see. Things that you missed in which category?
I hear like so many benefits both for the students and for your patients. I guess one thing that comes to mind, what is your experience as a preceptor? Like what benefit do you find that you get, or what do you struggle with in doing this longitudinal care of your patient panel over a year after year?
Well, I think that the patients get attached with the students. They, mostly uniformly when I go into the rooms, say, oh, this person is going to be a really great doctor, or they've enjoyed having them. And one of the benefits is that most of the time, then we ask them, would you like to, have a student that, my student is leaving and but I'm getting another one. Do you want to work with the student? And uniformly, the answer is usually yes. Unfortunately, I can't always keep the same patients with having a student because a lot of those longitudinal relationships form kind of germanely because my staff schedules patients, and sometimes it depends on who got scheduled, what the medical condition is, and then how successful we are getting that patient back into the student schedules. But it does require it requires a commitment from both the student and the preceptor in making that happen. Because and the staff can be super helpful as well. But you have to really pay attention to the schedule and sometimes be a little bit creative. Yeah.
That makes perfect sense. I know you don't know what is going to happen over the course of a year. Any other tips you would give newer preceptors to the LIC as we wrap up?
Really to like use the students as an extension of yourself. And we also have a lot to learn from the students as well as that they can learn from us, but they can really be helpful in terms of communication is key. Also, communicating test results, involve your student in all aspects of care because it is really important that they learn how to do these things so that they're not learning it when they're doing their sub-I or when they're going out into practice. So that includes, and yes, it's much more efficient for me to write the prescriptions than and to put in the orders than to have them do it. But if they can't, be putting in their first order when they're, on the wards or when they're doing their sub-I. So involving them in all aspects, including putting in orders, prescriptions. I think that now with electronic prescribing, there's some skills that are being lost, like even like calculating doses for things. So I make sure that they're, at every visit, they're calculating the appropriate Tylenol and ibuprofen weight-based dose and not just, what it says on the, on the bottle or what the electronic medical record puts in so that they have those skills. So I think that's really important. It does take more time, but as they get better, as they get more practice, they get better with this, and it is important skills that you're teaching them as well. So that's another thing that I would advise preceptors to let the students do. But then remember to sign the orders because they don't go through.
Yes.
So sometimes I forget, and then the next day the prescription didn't go through. What else? I thought about something and I forgot.
Well, you're thinking, I wonder what expectations you give the students. For example, is there an amount of time that you expect notes to be done or like results to be communicated to a patient?
Yes, so I give them the same expectations that I do. I do have high expectations, but I give them the same expectations that I give the residents. So the notes should be completed within 24 hours. Orders should be placed that same day and signed. So as I said, sometimes I'm the weak link in that because the order is placed and then I forgot to sign it. Anybody going to an ER or to another setting, like that note needs to be done right away. So it may not be as, detailed in terms of like the clinical reasoning as I would like, but they, notes have to be done so that other providers can have access to it, especially if they're going to the ER. So that's super important. Yeah, so most of the time they're able to do that. The test results part, if it's something urgent, I'm going to be dealing with it anyway. But I do send it to them and ask. And I find that in the beginning of the year, that's hard for the students, but they, toward the end, when they have more autonomy and they feel more empowered, they are much better able to do that even when they're not at that site. So like with everything, it's a progressive learning of skills. So test results should be communicated, reasonably, especially if they're abnormal, they should be communicated the same day. And if they're normal, usually I'll wait till the student is there the next week. Obviously, if the patient's on the portal, I've already communicated that result that they've seen it.
Absolutely. Thank you so much. It's really inspiring to think about all the ways that students can help support primary care patients. I really appreciate all your expertise and your time today, Dr. Cineas.
Thank you for having me.
Of course.